Now we would like to invite Miss Lynna Chandra. Are you there, Lynna? I think she should be. Yes, hi, how are you?
I'm good, thank you.
All right, so Lynna Chandra is an Ashoka and Atlantic Fellow, board member of Assisi Hospice, Singapore, and board member of Common Purpose Asia Pacific and trustee of Common Purpose Charitable Trust UK. Lynna founded Rachel House in 2006 to pioneer the first pediatric palliative care service in Indonesia and helped champion the establishment of a palliative care ecosystem to benefit patients with life-limiting conditions. Driven by the conviction that no child should ever have to live or die in pain, compassion was the underlying foundation of the organization, and equitable access its reason for being. Lynna has since embarked on a new journey in search of an equitable, humane healthcare model to ensure compassionate and excellent care is available and accessible for all in an economically sustainable way. Today, Lynna will be sharing on a return to community care, lessons of love, dignity, and collective wisdom. Welcome, Lynna, to the conversation.
I'm just going to go ahead and share. Now, let me just take that up. And hi. Okay, that was a good morning with so many conversations, and my mind is still reeling from Ayesha's talk. So, good morning and hi to everyone. So, would you like me to just jump straight to the slides? Nat? Okay.
Yeah, feel free, go ahead. I'll be here. My face will still be here.
So to follow through from the two conversations this morning, I thought, let's go back to the community and caring for the community and bringing better access to care. And the topic that Nat and I sort of agreed on was how we can talk about what we've experienced at Rachel House, which is a great lessons of love, and how to bring dignity back to community, even in the most dire and devastation or the most horrific part of the journey in one's life, which is the loss of a child, and how we can actually build that community with collective wisdom. So a little bit about Rachel House. We're the first pediatric palliative care service in Indonesia, established in 2006. And it was, in fact, the first organization that basically outside the health system that advocated for the use of painkillers like morphine, with a lot of help from Singapore. So while the service in Indonesia, our history is very, very connected with Singapore, I don't think we would have actually accomplished what we accomplished in the health system, bringing morphine, bringing palliative care into the hospitals and all of the public hospitals in Indonesia without the help of Singapore. So for that, I'm eternally grateful. And I think I often hear today from various people, including Prof. Chow, about how teams in Singapore are still going down to Indonesia and impacting change. So Rachel House is made up of a team of palliative care trained doctor and nurses. For many, many years, we functioned only with nurses. It was intentional. I'll go into that a little later. But we're a team of palliative care trained, first palliative care trained team of nurses and doctor to provide pain and symptom management for children who are seriously ill, and predominantly we look after children with cancer and HIV from the poorest parts of Jakarta, free of charge. The first team of nurses, I think we're well known for a team of nurses that basically went on the motorbikes to reach patients' homes, because that was the fastest way for us to reach the homes of children in the most crowded and densely populated parts of Jakarta, where traffic is horrendous and is notoriously bad. Our vision is no child will ever have to live or die in pain. This is probably worth talking about, particularly where we came from Ayesha's talk about how I think when we look at Marie's talk this morning about women in global health, and then Ayesha's experience about building a different organization and solution on the ground, where I think fun and love and fairness sits at the core of the organization. Often we forget that women in organizations, and especially women as leaders in organization, can actually impact in such a profound way, purely because I think we're unafraid, and without knowing, I think we're unashamedly brave in talking about our feelings, if we have the wherewithal and the environment to shape that conversation. And I think this vision of no child will ever have to live or die in pain, coined back in 2006, 18 years ago, is something that, as a former investment banker, I really didn't understand the challenge or the impossibility, perhaps, of this particular vision. But it has, over the last almost 2 decades, shaped every conversations that we have had at Rachel House, down to whether we would add another disease as our criteria for patients, or whether or not we would admit. So my apologies for slipping out. It actually gives me time to sort of regroup after Ayesha's talk, so that's great. It's my excuse. So the vision for Rachel House is no child will ever have to live or die in pain. And this particular vision, and I wanted to take it back to some of the discussions that we've had this morning, that made me realize, while listening to Marie and Ayesha, that we often don't realize the profound impact of women-led organizations, in particular, our ability and the courage to go into the feelings of what we're looking at, and have the courage to perhaps coin a bigger vision. And this particular vision that came, and it was coined in 2006, about 18 years ago, came from the space of what I saw in the ward of the largest hospital, children's ward in Jakarta, where I was walking through the ward with a doctor who was showing me these 40 beds on each side, screaming children, sleeping on rusty beds, and looking out through these rusty iron grill windows. And if they were not screaming, then 2 or 3 of them were basically sitting up and looking extremely forlorn. And I was asking the doctor who was taking me through that ward why they were all screaming. And she said, because painkillers are expensive. What I realized then, or much later, was that it wasn't that painkillers were expensive, because immediate release morphine, as many of you know, it is quite affordable. But it is because doctors and nurses, at least where in Indonesia, we're not trained to look and turn towards pain. And aside from the myth that, morphine kills, that many still believed in Indonesia, and even and especially among the medical professionals. But I think what we found eventually was that the biggest barrier to alleviating pain, whether it is physical or emotional, or seeing the totality of pain, not only in medical professionals, but in many that we work with, is actually our own fear of looking at pain, our own fear of turning towards pain. And at Rachel House, this is what we learned over time, that as we train our nurses and mainly nurses initially, because I took the decision 3 years into Rachel House journey to do without doctors, because nurses in Indonesia were so disempowered that, and are still, that whenever there is a doctor in the room, they would look towards the doctor for all of the answers. And yet we wanted to train a different generation of nurses in Indonesia. We wanted to train nurses who are courageous enough to open their hearts, to look towards the suffering of children, the suffering of those that are actually completely bereft of care, those that many actually forget, those that are discharged from the hospital to die with perhaps just Panadol. And we saw that. We saw so many of that when our nurses would rock up, park their motorcycles outside the house, and heard screams coming out of the house. A 9-year-old with brain tumor discharged from the hospital 3 days prior, referred to us and sent home with just Panadol. So we wanted to train a new generation of nurses. And for that reason, in 2010, we decided to go without doctors and build this incredible team of nurses who, at the core, have the courage to open their hearts, to champion for the patients that they serve, to speak on their behalf, and to look always to gain more knowledge and more courage to just be by the patient's side so that they will not have to suffer in pain. And as a home care team, we also work closely with families. And this Buhilda was one of the mothers of our patients, former patients. Guntur died in October last year. Today, Buhilda is one of our team members as a community health worker. The reason why I put her picture here is because she is the first mother of a former patient who is actually in our team. Not only do we have nurses going out to patients' home, we've trained over 400 community health workers, today probably in the 800 range. And but we have 4 very special community health workers on our payroll, and Buhilda is one of them, and the first mother. The reason why she comes into our team, and we have invited her to be part of our team, is because while Guntur was very, very sick and was in comatose with brain tumor, he was always taken care of with incredible care. He never had pressure sore. He was always kept very hygienically clean and very comfortable. And while he was in a shelter, Buhilda was always the person who helped all the other mothers who came through the shelter to make sure that they were not alone. They knew how to navigate the health system, and that they had all of the care that they needed, that she had to learn. When Guntur died, we asked her to be part of our family because sadly, 6 months before Guntur died, Buhilda lost her husband in a tragic motorcycle accident. So bereft and without family, she was really alone in her grief. And today she's part of our team, not only sharing her courage and her resilience and her knowledge of how to take care of patients and children with cancer, but she's also the incredible love for a lot of our patients' siblings. And while our nurses look after patients, we often send in community health workers to be with the siblings to make sure that the siblings are not left alone. And here you can see a picture of Buhilda with one of our patient's sisters, who is often perhaps forgotten because of the attention that the mother has to give to the patient. But Buhilda is always there, whether it be, we have so many pictures of her just drawing with patients and just loving them and giving them all of the love and attention. One of the most wonderful thing about this is, as I speak to her, Buhilda has now been with us for 6 months or 7 months. So I speak to her, she talks about how in giving her love to these patients and these children, even though her heart breaks again and again in memory of Guntur, but she learns to receive love. She learns that there is this flow. As she gives her love, she receives as much love in return. And that's the powerful part of what this work is all about. And we hear it from Ayesha, what she talked about, and also in Marie, that as we allow our love to flow, chances are that we receive so much more. I put here a picture of a man and our second male nurse in our team. And we talk about gender equality and how women in global health play a significant role in changing the future of health and global health. I've talked about how we bring care to the homes of our children, and mainly led by nurses, and we now have a doctor who is also a woman on our team. But we have 2 male nurses on our team, and these are just beautiful men. And one of our male nurses now has been with us, Dadan has been with us for 8 years, and Zaki has just joined about 5 months ago. One of the things that Zaki talked about after 3 months, when I spoke to him, is this awe of seeing a group of people that he had learned about palliative care briefly in university as a nurse, but he had never seen it in practice and in real time, where a collective or a collection of people, a tribe of people, go out together and look after patients. Zaki may have to go alone to see this patient, Alfin, but he's never alone. Whenever he flounders, whenever he feels uncertain, he always knows that there is a backup. Whenever his patient runs into trouble, there is a group of our nurses and community health workers who would back him up. On weekends, he talked about how if one of his patients needed to go to the hospital, he only needs to tap into all of our team to make sure that the patient gets safely delivered to the hospital, and where doctors are called to make sure that in emergency care that they're taken care of. I think some of you may know about the state of healthcare in Indonesia, where it is really difficult to get attention. Sometimes in the emergency ward, you may have to wait for 2 to 3 days before you're given attention and given a room or a bed. So Zaki knows that with a team of people behind him, he can actually make available the care. But let's talk about gender equity and the role of men in healthcare. I firmly believe that there are many men who would like to participate in caring for patients or their loved ones, but perhaps there are no templates for them to actually participate in that. And I think that's part of the discussion that we perhaps need to have in future. This is Zaki with one of our patients in a tight situation. And this is, I chose this picture for us to see where this is a situation for most of our patients where the rooms and the homes are so small that our nurses have to squeeze in a very tight space. And for some of us, maybe we can think back about COVID situation where in a densely populated areas with no windows, these were some of the most, I guess, risked patients or patients that are at high risk with HIV, TB, and unvaccinated because they didn't even have the capacity to bring themselves to the public health clinic, to the polyclinics, what we know here in Singapore or Puskesmas in Indonesia, to actually have vaccination. So our nurses have to work in these environments where first they have to take care of the physical symptoms, but they also have to take care of a lot of the emotional and the psychosocial issues and the financial issues for our patients and the families. And through it all, it is about giving their love, because I can't imagine anyone else would want to do this job if they could actually be in a hospital. Why would they work in this environment if it weren't because of the love that they have experienced? Not only the love that they have in their hearts, but the ability to actually express that love freely, and the safety in the safe environment where they know that behind them, maybe not with them by their side, but behind them, they have a whole team of people who will always back them up. And that's a collective wisdom that we talk about often at Rachel House, that we are part of a family, that we know we're never alone. Another male picture. Once again, we talk about gender. This is Alvin, who sadly passed away last weekend. Alvin has only his father to look after him. And initially, when Alvin came to us, his father floundered. He didn't know what to do. And he didn't even know how to take care of Alvin. But with us by his side, he was shown how to give his love, and he didn't panic. He knew exactly what to do, and he stepped up. He stepped up to basically take care of Alvin through the end. And this is where I think what I've learned at Rachel House, that not only Alvin's father, but everyone, whether it be nurses or our community health workers, or even the doctors in the hospitals that we work with, who are our partners, if we provide the environment of love and the ability and the safety net for them to actually express their love, I think we would go a long way to actually be able to invite people into the realm of, and the courage of expressing their love, in the knowledge that as we turn towards suffering, we're not alone. And we, in fact, are given the opportunity to express our own humanity in the most incredible way. This is Alvin's father from another expression, and I chose this picture because I wanted to show us that it is not the picture that you see in that photograph that we printed for him is one of him expressing love. But here you can see the dignity, even though the sadness is expressed through his eyes so clearly, but the dignity and the peace of being able to take care of his son till the end. And that is a community. That is what we offer when we go out and stand by our patients and their family to let them know that they are safe, they are with us, and we are with them, and they're never alone. The impact of our service has, over the last 18 years, has reached incredible numbers. But I think most of all, what we are most proud of is the community of hope that we have actually established, and a community of safety net for our patients and their families. Ensure that everyone has access to care, and in an empowered community way, and in a community of love. Here you see one of our patients with her mother. It is not easy for a mother or a grandmother that we see who are alone to take care of their patients. But on that journey, it is much lighter if you have a whole community of caring people standing by their side. And a community can stand by can walk with someone who is sick, but a community who is tooled and who is given support and who is trained to take care of one another is a community that can rise up to provide that care and love for everyone. I'm going to stop sharing here and basically speak to, because I know that I've run out of a few of the time that I needed to give earlier. So let's get into some of the conversation.
Thank you, Lynn. I suppose my first question with you, thank you for sharing, what Rachel House is all about and your vision and your mission, and also some of the very heartfelt and almost somber stories, but also stories of hope and that, in the midst of pain and suffering that many of your members in your community and the workers that you've trained have, not given up hope and instead have gone back to serve the community. My first question for you is, how has your definition of what it means to be a woman in global health evolved through your experiences with Rachel House from the time that you left investment banking to where you are now?
I think, as Ayesha said, maybe I'm a little different from Ayesha in the sense that I think my years of investment banking are years where I was not comfortable in expressing my feminine side. But at Rachel House, I've been trained. Not in the early years. The early years, I made a lot of mistakes of still applying that brute force of that I can do everything if I push with that whole masculine warrior side. But over the years, I think what I've learned is the strength and the incredible power of falling into our feminine side. Whether you call it a motherly love or not, I'm not a mother, and therefore I don't really understand. I know I've seen the mothers and the grandmothers who look after our patients, and that I think is the holding power. So how my idea of women and women in organizations have been shaped by Rachel House, I think it's the ability for women to fall into the love and our freedom, hopefully, to express and be given the ability to express our love and the permission for everyone around us to express their love with courage. And why is that important? I think as we fall into the beauty and the love that is within us that everyone has, we give others the permission to fall into that. And I think everyone deserves to love and to live from that space and to feel what it means to the suffering of another and have the courage to actually open our hearts and expand into the suffering of another. Because when we take care of another in their journey of suffering, in their journey of pain, we affirm our own humanity. We allow our own humanity to expand. And we discover our own courage to sit with suffering, to sit with pain. And perhaps during that time, we give ourselves the permission to also look within and see our pain. We often say in the medical world, when doctors and nurses are not given the freedom to express or to explore their own pain, it may come out in a way, the most shocking way, in front of their patients and bleed, in fact, on their patients. Because we react, we get triggered, right? When we see suffering and when we see pain, often we either run or we react. And perhaps when we are allowed to express our own love, and I think as a woman, I feel that we have the freedom, more freedom perhaps to express that. We are allowed to actually lift our gaze beyond just the suffering of one, the suffering that is in front of us, but to look beyond in a motherly love and say, how can we use that love that is suddenly expanded to look beyond the suffering of one, but the suffering of all, and to find the solution, just like Ayesha has and Marie has, to look beyond just our own problem at that one time or the problem in front of us, but to create that collective wisdom and to look beyond and actually lift the gaze of everyone higher. And I hope I've actually answered your question that, that I think as a woman, we have the opportunity now more than ever to actually fall into our own space of beauty and love and bring that courageously to the space of work and to find that collective wisdom that we can actually collaborate. Because as women, we collaborate a lot better. That is, communities built by women. If you look at the community health workers that we built, that is how we have encouraged this network and this safety net for all of the community members in North Jakarta, the poorest area. Because by training them, we now built this safety net for everyone.
Right. Thanks, Lynna. I heard something just there where you said, that women collaborate better. And what I'm actually hearing from that is that women have this innate capacity to communicate. I almost suppose, or my own personal belief, is because we've been allowed to actually express more of our emotions and feelings. And that has actually enabled us to, empathize with other parties, empathize with other people, and also support other women. That I suppose maybe in our current society and very traditional way of viewing things, men have not necessarily been granted that same space to express their emotions or even taught what are the emotions that they need to express. And you said this earlier in your talk that the men that you've interacted with in your community, like many of them have no templates for caregiving. And that's something that they almost have to learn, you know, it's a skill that actually has to be taught. And I wonder if, you know, us as, if we can talk about or like explore the idea of what that will look like for us to actually invite the men into this space, and invite them to be able to express feelings a little bit better without it seeming to, I don't know, I've men in my life who say that, you know, they don't want to be too emotional. And I'm sure the women in this webinar may also have similar sentiments. So I just wonder like what we can do to kind of like open up that space and actually encourage those conversations to be had more.
Yeah, I think we're in uncharted territory, both for men and women in the world, right? It's like we have no rule books to play with. And this is a wonderful place to be in, because as women, I think I was in investment banking 30 years ago when I was the only woman on the whole trading floor. And I think today we are in a much different environment to look at. And it's the same thing for men. Men this generation are asking for permission or are inquiring how they can actually participate, but they have no templates. And so we still stand in this like men don't participate, and we often gripe about that, right? But I think if we lean towards another and we bring that curiosity and find out what are the challenges that men are facing, and why do they feel that they're not given the permission to cry? Why do they feel that they're not given the permission to feel? So let me give an example of Dadan, our one male nurse for the past 7 years or 8 years, but now we have Zaki. When Dadan first came in, he did not even feel the ability to actually connect with me eye to eye. And when his patients are dying, he felt, although he didn't want to let them go, but he didn't know how to actually express that. He didn't know how to express his love for his patients. And because of our female nurses seems to actually be able to fall into this, it's okay, we are allowed to feel and we can cry. But Dadan felt was finding it so difficult to actually do that.
Mm-hmm.
Today, he is the father for all of our new nurses coming in. He's the one who calms them down. He's the one who holds them when they're crying. Why? Because over time, he's learned. He's also been given the permission to watch and to learn from the women and from the women in our team. And I think often we don't have to actually have a rule book for everyone, because everyone is so different. And every man come from such a different family background. But I think holding space, we hold space for women when we are asking, you know, tell us about what is breaking your heart. And we are able to allow them time and just to listen. And what about for men? What if we don't actually put them in that box that they're not comfortable with feelings? What if we don't put them in a box where they are not at privy to actually express themselves? What if we ask them what is actually the difficulty? What are actually the challenges that they're feeling? I think like what you said, Nat, is about inviting them into a conversation and inviting them into just walking with them as they're caring for someone sick. It's and celebrating the fact that we are in this juncture of newness of everything. But perhaps we need to throw out that framework of men do not participate in caregiving. Mm-hmm. Sometimes it's even mothers' faults, right? Mothers who perhaps say, my son would never be allowed to actually take care of me. And it's his wife who I will actually expect to take care of me, right? Mm-hmm. Perhaps it's time for us to walk a different path,
right?
To actually look at things differently.
Mm-hmm.
And know that we don't have any templates to follow. we are the ones who will actually create the future of what caregiving as a team between men and women would look like.
Thank you. So earlier you mentioned, that Rachel House has actually grown so much in, terms of training up community health workers from the 400 to almost about 800 and 800 range now. Could you share a little bit more about, that kind of training for those community health workers, and also whether most of those community workers are male or female, and what that training actually has provided for them?
They're all female.
All
I call them
800
the
of
gossip
them.
mothers, right?
Right.
I call them the gossip mothers in the community.
Mhm.
Probably not very nice of me to actually call them that, but there was a legacy to that. In 2013, when we first started looking at these community health workers, they were all women. And so Indonesia has a huge, long history of kader, or cadres. And it was set up by President Suharto, the former president. And these women are not trained, but they are the women who basically weigh the babies, advise pregnant mothers in their community. And we leveraged that whole system of cadres to basically begin and launch our community network in palliative care, which is basically a training platform for all of the community health workers. Why did we do that? Because when we used to go into the community to look after one patient, these women, gossip women, would sit outside the windows and look in and say, oh, that child, you look after children like that. I have a child around my neighbors or next door to me who has the same symptoms. Could you come? We quickly realized that they know everything in their community. They're the ones who know who is sick, who needs food, who is basically having an affair, and that kind of thing. And with these available resources, we decided to actually go into the community and ask if we could layer on top of what they're already doing certain skill sets, would they want to learn them? And those were basically learning to actually work with the community and asking, what are you doing now? We're not trying to change what you're doing, but we're just layering on top of what you're doing so as to basically allow you to better care for your community. So what do? We train them in 4 things. 1, to identify those who are sick around them, at home alone, and to identify what kind of illness that they have so that they can actually call the doctor. And this is the connection that we give them, to call the doctor closest to them about what kind of sickness and what kind of symptoms they're seeing in their neighbors. 2, to bring the patient or those who are sick in their community to the nearest clinic to make sure that they can access care. And if the patient needs to be referred to to a secondary care or tertiary care hospitals, then they will bring them to those hospitals. So we need to train them how to navigate the health system. Number 4, when patients are discharged to go home, then these community health workers will be at home helping them to basically provide food, clean their house, and help them basically, get better care at home, and to rally support from the community. So these are the 4 things that we train community health workers to do.
And what does that training kind of like provide for them, on top of the skills that it gives them? Like how does it influence like their position in their community and society?
Yeah, and that's really important, right? Because I think I actually when I saw how, because we don't pay these cater, right? 400 or 800 of them, and I started asking them, why do you do this? Because they're poor. They're like as poor as the community that we serve, right? And so when there are floods in the area, their house will be the first one that gets flooded. And yet these women turn up and show up to look after their neighbors. So I asked them, why do you do this? And they said, well, 1, because we have always been interested to basically take care of people. That's part of the innate sort of nature. But 2, we suddenly are respected by our community, right? Because we're now the people who they go to. We're now the center of our community. And they are. These are the women who, as we train them, and they don't ask for anything other than a T-shirt with Rachel House logo at the back. And it's really funny because they would actually design their own T-shirts, and that's what they would ask for. But we don't pay them. And, that one time when we started out, there was this patient that this woman one of our community health workers found a patient next door that needed help, but the polyclinic closest to them is beyond her neighboring sort of, boundaries. So she called a friend, text message a friend, and she brought this man to the border of her community and passed this patient along to her friend in the next community so that she could bring this patient to the nearest clinic. And these are the incredibly resourceful women. What we needed to do was simply to give them the knowledge, and they found themselves all of the resources that they need. Today, they're our network. When we need to find out where there are free HIV tests, CD4 tests, or viral load tests, they're the ones who basically know. They're the ones who know what organizations are giving free food. And if our patients need them, they're the ones who we tap into. If we find a patient in a community where our community health worker doesn't actually take care of, we will find the connections through them so that that community health workers can actually support our patient. This is the power of the network of women that I think we are just learning to tap into.
Awesome. Thank you very much. So my colleague actually had a comment on, the distinction between emotional caregiving that is more stereotypically female and the financial caregiving that a lot of males are expected to provide in traditional society. And I wonder what like your experiences have been on that, and especially with Rachel House being predominantly women.
This is a sad part about how we box our roles in, right? And I think it's time for us to actually open up the valve and expand that box. Because, I think I heard earlier that men are not given paternal leave. Some men actually want that. So at Rachel House, we have grandmothers who basically are the caregiving givers for a lot of the HIV children because their parents have died. And these grandmothers actually have to be the sole breadwinner. Men, like the Alvin's father that you saw, he's the sole caregiver for his son. And yet the burden of the financial and, that not being able to feed his son and his family is huge. And I think this is where gender stereotyping can be so harmful.
Right.
Because there are times when women are the breadwinners, and yet we feel sometimes judged by the community, by society, that our husband, why is my husband not the breadwinner? And we even have to sometimes apologize for that. And
what they were talking about.
exactly, right? And I think perhaps it is our own stereotyping that is creating that suffering. It's time for us to actually throw that out. At Rachel House, we see so many of both sides. We see fathers who are the caregiver, mothers who continue to work because when a child is sick, sometimes the child is actually closer to the father. And mothers are rigged with guilt because, at the hospital, nurses are judging them, right? Why is your husband coming and you're not here?
Right.
And even in healthcare, we have biases. And perhaps it's time that we actually throw that out.
That's a great point. That there's bias in the healthcare system towards, gender roles.
Yes, the
One
biases.
final question for you. We are running out of time, but I just have one last question for you. Does Rachel, so, we've had like some great conversations about, about like the power that women hold in the community and really what they're able to achieve when they like band together in solidarity. And but just out of curiosity, does Rachel House plan on engaging more of the male figures in becoming and training them to become community health workers as well, or is that something that you envision will still be predominantly female oriented? Just out of curiosity.
Yes, currently we leverage a lot of the existing cater. In Indonesia, there is another group called the youth group. We have a video on our YouTube, Rachel House YouTube, that shows how we leverage community health workers. And there is one male youth that we have trained. And he's a different sort of youth. We hope to have more. There are a couple of actually limitations, and this is societal limitations. We seem to actually allow and feel comfortable with women's strangers stepping into our homes to take care of our sick ones rather than men.
True.
Right? We seem to have this this fear of young men coming in, expressing their desire to help, and fearing that they would actually do some harm to our family. So those are the stereotyping that perhaps needs to loosen up before we can train more youth, male youth, to actually help our patients.
Great
And don't get
point.
me wrong, I have that stereotyping too.
Yeah,
Because
many of us
I
do.
have fears. Yeah.
Yes, exactly. Yeah. Okay, thank you so much, Lynna. We're gonna wrap this up, and I'm gonna hand back the floor over to Evelyn, who's gonna lead us and moderate the upcoming panel.
Kind of like to say congrats, Natasha. I think I think for everybody on this call, I kind of want to say that, you know, this was really Natasha's idea. She really pushed this forward on wanting to, you know, talk about women in global health, and she was the one that told me like we should do something about that. And I just really wanted to say thank you very much for the education associates. You know, both Glenn and Natasha have been very active in this, especially Natasha. So I think we should all give her like a electronic round of applause. Thank
Oh,
you
thank
very
you.
much.
All the reactions coming in. That's so sweet.
Okay, so now we've come to like the panel discussions, and honestly, I think the panel is really just an extension of question and answers, right? But you have a whole, people in research, people on the field, people who are inspiring to be, someone who can be on the field as well. And I just thought that, with Glenn and Natasha here as well, and all the other people on the call, and I know that you guys on this call have an interest in either working on the field, interest in actually doing some research there. And this is really just like a network, I guess, a webinar for any other questions that people might have that's not covered in the talk that we gave, right? It could be something along the lines of, how do I even start something, or how do I even have that discussion about something, or where should I go? What's the next step? What do you think are the education I should be getting in order to make a step into this field? And I just thought that I'll just keep this chat as well as the question and answer open, just to see whether or not anybody would like to ask any question on this topic. And we'll just keep it as organic as possible. I don't really want to give like a time frame to it. If we really ran out of questions in half an hour or 10 minutes, we can call it a day too. I think everyone had a very long morning. So feel free, raise your hands, lower your hands, ask the questions. If not, maybe I'll just start. And I think this question is something that a lot of the speakers have mentioned in their own field. And it's something that I also want to, personally ask everybody. I think to me, role modeling is something that's very important. Role modeling women and females who are working in the ground, learning from them what they do, the path that they take, is something that I find that's very important as well. And this mentorship is not just at the level of in the global health field, but also in the academic field, also in my clinical areas and so on and so forth. Perhaps you could share with us some women whom you have taken as role models in your life, how they have impacted you, influenced your own path, and whether or not that's something that you'd be willing to share with the rest of the team here. Maybe Lynna first?
Wow. The woman who most inspired me is not in the working field, but it's someone who is like a foster mother to me. Why? Verna was not educated in the way that we are today, like in universities or anything, but throughout her life, while she was alive, she was the champion for everyone around her. She was the community advisor. She set up the first care for children with Down syndrome and autism in the community, to allow mothers to have their day away, respite. And she set up basically the champion sort of organization, advocacy group for Aborigines in the entire Australia. And she made it her business to turn towards any inequity, any discrimination, and made it possible for people to live a better life. And this is on top of her being a mother, being a church sort of, leader. And throughout it all, it was never about turning people towards Christianity or anything like that. It's about showing kindness. It's about being there when people are needing help. And I think that showed me the way, and that showed me why walking with is like Ram Dass saying, we're in the end, we're just walking each other home. And I think that's the most powerful lesson I learned from Berna.
And Marie?
Yeah, thanks for that question. I think there's, reflecting on it, a lot of role models I can think of, and for different reasons, I think have probably helped me in making me who I am today and where I am today. Even early on, I mean, school is one thing, but once I reached university, having internship opportunities with zero work experience. I remember this woman called Brigitte who ran this NGO that did human rights advocacy with the EU Parliament. And she was just running the show by herself. And she said, come and help me. And I was basically just, no experience. She gave me all the responsibility. I could lead delegations, and I was just loving it. And it was very empowering. And I just continued, working hard because I knew that there were many exciting opportunities out there. Similarly, I guess in every job I've had so far, there's always been one person. There's many that haven't necessarily been a good influence, but some have said something that have been a positive trigger, and links to what I read this week also on the power of feedback, positive feedback and compliments, just as we reflect on our role as mentors. Giving positive feedback to whoever you work with, or compliments to your friends, that can be so powerful in making someone reflect and be like, oh, actually, I guess I'm good at that, or I guess this suits me, or I guess I didn't realize, but people appreciate my capacity to listen, and they don't necessarily expect me to open my mouth all the time and say something for the sake of it. All these things can help in your reflection to figure out who you are, where can be your best contribution, what your limits are, what you're willing to accept, not accept. And just in how I try to be a mentor, the best way possible is if ever I am working, people that work with me, I always want to give them visibility, responsibility, and visibility, because if you do that, then they feel accountable to the work. It's more motivation, it's more gratifying. So that's really how I like to mentor, so to speak, in a working context. And I think it's worked well so far. I think it's been appreciated, I hope. And we've had really good working relationships with most of the women and men that have worked with me. And then my sons, I mean, I have 2 boys. And so for me, even when I reflect on, okay, do I want to take a break from work now because, just had a second or whatever, I also reflect on one aspect, which is I want them to know that their 2 parents are equally occupied with work and equally available for them. That's what I just strive to reach to. So, I mean, that in terms of like setting a role model, I want them to understand that both man, woman, both mom, dad can be at work, and is allowed to go on a business trip, things like that, so that they have a vision of equality. Ideally, that's the toughest task.
Oh yeah, I think I think that's a great kind of looking in the future and hoping what we can do to build the next generation that comes after us on how we want to enable both the male leaders as well as the female leaders, right? Because at the end of it, advocacy has to come from both sides. Lynna, just now throughout all of the conversations and all the talks that was ongoing, I've always been very heartened by all your comments in the chat group. You were very involved in the questions, and I love that, because one of the reasons why I also thought that a good platform like this should be done is also just to bring people who work in the same field together, and get to know each other and to learn from each other. And maybe Lynna, maybe you could share, what are some of the takebacks that you think we should be having, or the people in this group should be having from this session, right? What are the key things that you want people after the session, when they go about their normal lives, that you want them to remember from all the talks that we had today?
I think it's the fact that we should be more accessible for each other, right? And I think associations, the path going forward is uncharted. We are at the threshold of the greatest change on earth, whether it be because of technology or the way the young people are less and less connected because of technology, the advancement of AI. There is no way we can walk alone. And opportunities like this from bringing people who are like-minded, and Marie, your organization of global health, and I'm still asking the question, why aren't there more men who are stepping up to join that organization? Perhaps we can lean in and ask perhaps the opposite question. What has actually prompted the men to join the women in global health, the few that you have? Perhaps we should ask them, why did you come? And what prompted you to come? The future will have to be co-created by us together, men, women, and all other genders that we have today. And it's not just because we want to hold hands together, but it's because there's so much richness in all of our walks together, right? I mean, I still remember your story, Evelyn, when I asked you, why are you doing what you're doing, right? And because of that one boy that you met far away from Singapore. And what opened our hearts, what breaks our hearts, right? And it's the pain that actually cracks the shell of our understanding, right? Pain is the breaking of the shell that encloses all of our understanding. That's Rumi, and actually that's Khalil Gibran. But if we could work together, if we could walk together, if we could, through this platform, reach out to one another. Somebody just asked, because they're two ex-investment bankers, can we actually now, do female financial literacy? Yes, of course, right? Let's create the platform. Let's create that platform to do it for farmers. I want to know, like, what is the gender inequity among farmers? And what are the barriers right now? If we could all bring together the solutions, because solutions comes from co-creations of solutions. So yeah, I have big dreams for platforms like that in terms of what we can co-create for the future. But that, Evelyn, lies in how easy would it be for people to connect with one another? And what are the platforms that we will use to ensure that these conversations continue?
Yeah, no, I agree. I think platforms are important, and I'm quite happy. I know Prof. Chawan Cheng is here, so thank you, Prof, for giving me this opportunity to really just come about and have all these gathering of global health and like-minded individuals to come together. But really, I think Marie and you've been posting on the chat. Really, thank you for that. I mean, WGH Singapore is that platform, right, for women in global health. I mean, that's the aim that you're hoping to get from the networking and from all the associations as well.
Yeah, that's right. So, I mean, just to build on what Lynna said, I think, community, linking with each other is key. It's what I said earlier as well. I mean, also, listening to each other's stories. That's what we've been doing today, is very inspirational. I mean, the work that you presented, Lynna, is extremely inspirational. Same with Aisha. And I'm thinking also, the back of my mind, through Women in Global Health Singapore, since we're talking global health, since we're talking giving back to the community, promoting equity also beyond Singapore, I wonder if there's also a way that we could kind of share information about volunteering opportunities beyond Singapore in the global health realm. Sort of where can you give back to community? I don't know if you accept volunteers at Rachel House, but any way to give back in different settings where you're improving well-being, you're improving livelihood, and you're supporting women as well by doing that. So I wonder if Women in Global Health Singapore could also be a channel for that. But in terms of the other recommendation, I'm just going to add, I think we talked, Lynna, you mentioned it as well. We talked about love. It could be the fifth L of my takeaway list, because when we talk about leadership in general, why can't we just redefine what good leadership is? And there's a lot of writing on that as well. But in so many work settings, leadership is about power, authority, speaking loudly, and there's so many different ways of leading, as we talk. As we saw from my fellow panelists today, just leading with love, like choosing what you want to do from the heart, finding the opportunities because you know what the community needs are, and working with them to set something up. That's the basis of leading with love. So I'll just stop there.
At Rachel House, we often say that the most powerful tool that we have is love. Nothing, not even the sharpest words against us can ever hurt us if we continue to hold love in our hearts. And so it is the most powerful thing that we can fall into, because that's the greatest weapon.
I feel like we should just end the talk here. Like that's the best.
No, you know what?
I mean?
So women form the greatest network of volunteerism at Rachel House. So, even just what's happening this last few weeks, if I could just explain to you what this beautiful network of love is, generated by women. A woman who is Berkeley grad for Berkeley architect and then education from Harvard circled back to me after 16 years and said, we would like to see what we can do for Rachel House. And because for Rachel House, our next big dream is to train as many nurses as possible that we can actually send out into the rural area to start something similar like Rachel House. Whether they call themselves Rachel House or not, we don't really mind, so long as they can actually provide symptom management for those who in a rural area have no access to care. Now, what Dewi has is communications ability, right? Basically education. She can write curriculum. But she said what is really important in Rachel House is not just strict curriculum, but the soft skills, the ability to love, the ability to lean into suffering, the ability to actually reflect of self-love, the biases. And so that's what she will write into the curriculum. So as we train, we also will train people in all of the soft skills as we send them out. Then there is a director of Ministry of Health here in Singapore who actually originated the EPA, that whole sort of how do you measure someone's performance and capacity, and when do we know that they're ready to be sent out? Now, Mabel is about to actually volunteer her time to help us develop EPA so that as we train all of these nurses, we know when they're actually ready to actually survive in the boondocks on their own. Because on our own, we don't know how to do that. We don't have the capacity to do EPA, not even for ourselves. And that's another woman in the sort of the equation. And then we have an ontological coach who has just been introduced to us and who will help us create our HR, our recruitment, so that we can use that systematic recruitment of what are the critical skills to actually recruit these nurses that we can actually one day send out into the rural area. These are all women, right? It's just the most beautiful thing that I think the network of love is just spreading out. It comes from one vision that we want to train more and more nurses to be sent out to the rural area. And then this network of beautiful people coming to our sphere.
Other than putting up plenty of heart and smiley face emojis and lots of thumbs up, I think there's no other way I can verbally express my inspiration and really just the whole network itself, right? And what you talk about, bringing people who are like-minded, but each of them contributing in their own manner based on their own soft skills. I think it's something that's very lacking or that we don't talk about, right? often, we are seen too weak or too meek. And I think that's something that there's actually strength in that, right? The strength in that meekness and the strength in that patience as well.
Yeah.
I am well aware of time, and I'm also well aware that everybody has been here for the last 4 hours. And I really, really greatly appreciate the remaining people who are here and listening to us in the panel. I think all of us are readily available, and I'm sure I can speak on behalf of Lynna as well as Marie that should you guys have any further questions, feel free to just PM them, DM them, reach out to them on LinkedIn. I would really like to greatly appreciate SDGHI for really helping us to host this whole webinar series, to Glenn, to Natasha, and to the rest of my committee in the education. Really thank you very much. To Marie, to Lynna, and especially to Aisha, who's not here. Really thank you very much for your time. Thank you for all the emails here and there and for really volunteering to come down to talk to all of us. Once again, thank you very much. And should you have any other further questions, feel free to write to us. With that, I come to the end of the session today. For all those who are left here, if you have any feedback to us in the education committee of what other networking sessions we should have, maybe men in global health, maybe volunteers in global health, do just scan the QR code that Natasha has just flashed here. Give us some feedback, give us some survey and fill out the space so that we can actually improve ourselves and do better as well. So Nat will leave this on here, and to all the speakers and to all the participants, once again, thank you very much. This show will be this video will be available on YouTube. So feel free to also, come back to our YouTube channel. And if you just want to listen again, get the same inspiration, and I know I do, feel free to always just type in the YouTube link. Thank you very much, everybody.
Thank you, everyone.
Oh, we should take a photo. Should we? Should we not? Should we?
Yes.
Nat?
Yes. I can't take out mine because I'm flashing the screen, but.
Okay, let me just try to do this. Okay, wait, hold on. Let me add spotlight. Okay, I'll do it. Okay, smile everyone. Okay, good. Thank you.
Thank you, everyone.
Thank you so much,
Thank you,
Lynna.
everyone.
Good weekend. Bye.
Nice to meet
Have a
you
great
all.
weekend.
Bye.
Bye-bye.